Good evening, doctors. So we have some section of cardiology for MRCP Part 1 examination. So we will cover two topics today. One is congenital heart diseases and the other is a few arrhythmias, important ones. So I'll begin with a question. That is the only question that we have for today. The questions will be covered in the next class, the second one in which we do coronary artery disease. This is just to open up the class. So the question is that a 28-year-old man develops viridans group streptococci septicemia. Which of the following cardiac lesions has highest risk of developing endocarditis? Now, this is a very important question. We all know that congenital heart diseases are prone to develop endocarditis, but which one will have highest incidence of developing endocarditis is what this question is asking. Is VSD, ASD, secondum type, MVP with regurgitation, pure mitral stenosis, or asymmetrical septal hypertrophy? So it is a factual question. So factual question means there cannot be a direct logic for which the reason is explainable. But ventricular septal defect has been considered as a relatively high risk lesion for infective endocarditis. Others are also high risk, but not as high as VSD is. So mitral valve prolapse with regurgitation, asymmetrical septal hypertrophy, and pure MS, they are considered as intermediate risk, and ASDs are the ones who have the least risk of developing endocarditis. So let's see the congenital heart diseases. As already we know that VSD is the most common cause of acyanotic congenital heart diseases. So the congenital heart diseases are of two types. One is the cyanotic, the other is acyanotic. So the cyanotic means there's an admixture of venous and arterial blood leading to bluishness of the bluish discoloration of the skin tone. So TGA, which is transposition of great arteries, it is most common at birth. Overall, if you look at, like, this question had a 28-year-old man, so Fallott's tetralogy will be the most common overall. So if cyanotic heart disease, question is asked that which is the most common cyanotic heart disease detected at birth, that will be TGA. And if it is asked which is the most prevalent congenital heart disease in a cyanotic pattern, that is tetralogy of Fallot. Then comes acyanotic heart disease, which is VSD. Now, VSD does not become cyanotic because of the higher pressure in the left ventricle. So if at all any admixture occurs, it occurs from the left side to the right side. It is only eventually that because of this extra volume which is added from the left ventricle. Now I'll just draw this picture. So this is both ventricles drawn here. So you see, so here is a VSD. This is left ventricular cavity. This is right ventricular cavity. We know the pressures in the LV are much higher than the right ventricle. So this is the shunt. So if at all the admixture is happening, it is happening with the addition of oxygenated blood into deoxygenated blood. Now this blood flows to pulmonary arteries into both of the lungs. And because this flow, this volume is increased, this leads to pulmonary plethora. So pulmonary hypertension occurs, and eventually, because of pulmonary hypertension, the RV pressures, they rise, and at one point of time, it happens that there occurs a shunt reversal. That is, the pressures in right ventricle are higher than the left ventricle. This leads to development of a condition known as Eisenmenger complex. So the RV pressures, they rise beyond and above the left ventricle, and hence the shunt begins to develop, which is like deoxygenated into the oxygenated side. So overall, tetralogy of Fallot is more common than TGA. Fallot doesn't usually present until first 2 months of the body following the identification of murmur or sinuses. In newborn, TGA is the most common presenting cause of cyanotic congenital heart disease. Now, this was about the cyanotic. Now, let's check the acyanotic one. So, acyanotic, most common causes are VSD. It accounts for around 30% of total acyanotic congenital heart disease. Then comes ASD, then comes PDA, that is patent ductus arteriosus, then comes coarctation of aorta, and then aortic valve stenosis or bicuspid aortic valve. VSDs, they are much more common than ASDs. However, in adult patients, ASDs are more common new diagnosis because VSD will be known from right from the birth or maybe after some time after birth. But ASDs are usually diagnosed incidentally in adults. When they go for a routine echocardiogram, they are found to have ASDs. Cyanotic tetralogy of Fallot is the most common, followed by transposition of the great arteries, that is TGA, then tricuspid atresia, then pulmonary valve stenosis. So whatever that increases the admixture of deoxygenated blood leads to cyanosis. So let's quickly go into the first congenital heart disease, that is patent ductus arteriosus. So what is patent ductus arteriosus? Patent means persisting, remaining open, and ductus arteriosus is itself a blood vessel which exists during the intranatal period. That is, it basically maintains a junction, a flow between the pulmonary artery and the aorta during the child the child is in gestation. Why is it required? Because the lungs are full of fluid, amniotic fluid, and there is hardly any blood flowing through the lungs. And as such, the child is not breathing. The child is in the womb. Child is inside the uterus, surrounded by the liquor. So the child is not breathing. There is no air that is going into the lungs. So whatever oxygenated blood is coming, it is coming via the umbilical veins. So umbilical veins are carrying the oxygenated blood and they drop that blood into the inferior vena cava. Through the inferior vena cava, the blood goes directly into the right atrium and right ventricle. So during the fetal period, the right ventricle is the source of oxygenated blood. So it receives oxygenated blood and then pumps this blood into the pulmonary artery and into this thing. So the blood that flows to the pulmonary arteries, it literally, and then we all know that there is a persisting foramen ovale through which the blood goes directly into the left atrium through right atrium. So right atrium, the blood goes into the left atrium through the foramen ovale. So it reaches the left ventricle from where it is pumped out into aorta. So the blood that goes into the pulmonary artery, it will not go anywhere because the lungs, their blood vessel, the pulmonary resistance is very high in the intranatal period. So this blood is shunted from the pulmonary artery into the aorta through this blood vessel. Can you see here? Can you appreciate? So this is the pulmonary artery. This is the blood flowing into pulmonary artery, and from this there is this small blood vessel which connects the aorta and the pulmonary artery. This is known as ductus arteriosus. Now, once the child is born, this ductus arteriosus ceases to have any function because now the child is breathing, the oxygen enters into the lungs, the pulmonary artery pressures they decrease, and the lung starts to expand, so the blood flows into the lung. That means the RV now starts to get decompressed because of the blood flowing into the pulmonary artery. So now pulmonary artery, the blood flows. Now there is no umbilical vein. So this is all deoxygenated blood. It goes into the lungs, gets oxygen, comes through the pulmonary veins into the left atrium. Through left atrium, it enters into the left ventricle. From there, it goes into the aorta. So if the PDA continues to be present, then the aortic pressures are higher than the pulmonary artery. So there will be some blood will be lost again into the pulmonary artery. So that means, again, the blood flow will be increased into the pulmonary artery, and the pulmonary artery is not meant for holding so much of blood. So it will eventually constrict on it, leading to pulmonary hypertension and plethora of the lungs, recurrent chest infections, and so on. So, and pulmonary edema as well. So what we see here is that the ductus arteriosus needs to be blocked, needs to get obliterated once the child is born. So that is the natural course of action. But in some cases, this ductus arteriosus ceases to stop, ceases to get obliterated. So that is known as patent ductus arteriosus. So this is an acyanotic congenital heart defect. This maintains a connection between pulmonary artery and the descending aorta. So this is important terms that you need to remember. It is descending aorta. It is not the ascending aorta. It is a descending aorta in which the junction is there between the pulmonary artery. More common in premature babies because the switch on and switch off button is not working well in the premature babies. They're born before time. So this junction can remain open. Or the ones who are born at high altitude where the oxygen levels are low, much low, uh, uh, to to trigger the decrease in pulmonary resistance that happens when the child is born. Or those children whose mothers had maternal rubella infection in the first trimester. So these are the three main associations of PDA. One is premature babies. Second, babies born at higher altitude. Third, where maternal rubella infection happened in the first trimester. So clinically, there is a left subclavicular thrill. There is continuous machinery murmur. So it's a pinwheel machinery murmur. Classical, we all remember it from our MBBS days. This was a very common question as an MCQ in the exam. Large volume collapsing pulse. Why collapsing pulse? Because diastolic blood pressure requires aorta to be a patent vessel. So if aorta has a rent somewhere and the blood flows out from the aorta during diastole, then the diastolic blood pressure will be low. So we will have hyperdynamic circulation. It is simple that earlier aorta had to deliver blood to aorta itself. Let us say aorta, ascending aorta arc and then descending. They are all different organs, if we say. Then the aorta had to deliver blood to descending aorta. But here, now the aorta is not only giving it to descending aorta, but to pulmonary artery as well. So the diastolic blood pressure becomes a little lower than normal. So it's a hyperdynamic circulation. There is a wide pulse pressure, and these patients will have heaving type of apex beat because now the left ventricle will have to generate much greater force to pump blood through two foramens. One is into the aorta, and then second is through aorta into the pulmonary artery. Okay, so what do we need here? So the biochemical evidence for the patency of this ductus arteriosus hinges onto the fact that the prostaglandins, which are present during the fetal period in high concentration in this area, they keep it open. So anything which is prostaglandin inhibitor, like the non-steroidal anti-inflammatory drugs, specifically indomethacin, it has been conventionally used to close the connection in majority of the cases by exerting its anti-prostaglandin action. Sometimes in which endomethacin was not probably used or missed, then these cases require a device closure. So we have a butterfly shaped or a this dumbbell shaped device which blocks the PDA from the aortic side. So you go through the uh, arterial circulation. Just a second. Hello. सत श्री अकाल जी जी जल्दी बोलो मैं ना क्लास ले रहे हैं जी ਮੈਨੂੰ ਤੁਸੀਂ ਨੇ 5 ਵਜੇ ਦੇ ਬਾਅਦ ਫੋਨ ਕਰਨਾ ਮੈਂ ਤੁਹਾਨੂੰ ਦੱਸ ਦਿਆਂ so basically this is the pulmonary artery and this is aorta. So there is this connection. So we go through let us say, through the lower limbs. So we take a catheter, we go right up here, and through the aorta, we reach here. And we place the device, PDA closer device, on the aortic end of the PDA. So once we put it there, then the blood flowing from aorta into the uh, pulmonary artery, it ceases instantly. And eventually the patient will, this device will get thrombosed, and then the pathway is obliterated. So this is the course of action that one needs to follow in PDA. Number one is indomethacin, and number two, if if indomethacin is ineffective or could not be given, then you need to do a repair. Earlier, it used to be a surgical repair, open heart surgery used to be done. Not open heart, but mediastinum needed to be open, exposure of the blood vessels, and then ligature of the PDA. So you can imagine that this is aorta and connection. So we would ligate it somewhere here. But then that would require a stenotomy, opening up of the mediastinum, and then it is not required these days. We can just put in a occlusive device. Next is ventricular septal defect. So they are the most common cause of congenital heart disease. They close spontaneously in around 50% of the cases. So this is a true and false statement, that ventricular septal defects, they spontaneously close in around 50% of the cases. Non-congenital causes, they include post-myocardial infarction, and it is a mechanical complication. So it develops around 4th to 6th day after acute myocardial infarction. So just to name a few, the another one is acute mitral regurgitation, which almost always happens instantly because of the papillary muscle necrosis. And the later one to happen as a complication is ventricular septal defect. So the congenital heart disease, which is most common, is ventricular septal defect. It is classically heard as a pan-systolic murmur, which is louder in smaller defects. So smaller the defect, shriller is the tone. You can actually appreciate it much better. The larger the gap, sometimes you literally don't, hear anything. It is only on the echocardiography that you see an evidence of this thing, of the VST. Okay. What are the complications? So if the VSD is very close to the aorta, then it can lead to aortic regurgitation. Of course, it is a very common cause of infective endocarditis. Third is Eisenmenger complex. As I told you, this is basically the left ventricle. So this is the blood flow that is happening from left ventricle to right ventricle. But eventually, as the pulmonary blood flow increases, pulmonary hypertension occurs. There is a reversal of the blood flow that is known as Eisenmenger complex, and also right heart failure. There is a Fick equation. Now, this is a part two, basically, or a point for MRCP part two examination, in which typical questions are asked. So that is a Fick question in which, in the VSD with the left to right shunt, the shunt ratio can be calculated by using the Fick equation. That is QP by Q. That is basically is aorta minus MV divided by PV minus PA, where QP is pulmonary flow. So this is pulmonary flow. QS is systemic flow. And then aorta is aortic saturation. So it is oxygen saturation. MV is mixed venous saturation. These are all taken by the pulmonary artery catheter. And then PV is pulmonary venous saturation, which is almost the normal saturation that we see. And PA is pulmonary arterial saturation. So you can get these figures only from pulmonary artery catheterization, not done very routinely these days. But then to calculate if the fraction is if this shunt ratio is more than 2 in children, it is a cutoff for requirement of surgery, and in adults, the cutoff is 1.5 and more. So aortic regurgitation, as we saw here, is basically because of poorly supported right coronary cusp, resulting in prolapse of the cusp. So if somebody asks you, Aortic regurgitation is associated with VSD. What is the most common arrhythmia associated with ASD? It is atrial fibrillation. We'll do that in the next.